You know, I'm still smiling from hearing Dr. Brandon's talk. I mean, I thought, what a unique person, somebody who's passionate, and was not only funny, but it was like joyfully funny. You know, it was just really quite remarkable. Also, I'd like to state that as I begin and keying off of Temple Grandin's comments, number one is that I didn't get to skip algebra. And number two, I'm actually very sure that right now I couldn't do 100 sit-ups to save my life. It's like, wow. So in keeping with her ideas about to keep stretching, is that during my presentation, when this works, okay. All right. So let me just, let's see, is this going to work? Yes, it's going to work. Okay. All right. So in my presentation, I have autism in quotation marks. I'm a medical imager. In other words, I'm in the field of diagnostic scans and x-rays. So I'm not a primary care practitioner. And I'm also not a psychiatrist. So as I look at brain function imaging, which I have been involved in for 30 years, is that I come at this from the standpoint of just looking at brain function and seeing what it tells us, rather than coming from, there is a diagnosis and I'm going to go look at the scan and see how that matches up. In other words, the idea is from my perspective is that what you know as autism is a clinical diagnosis of certain behavior characteristics, and what I'm talking about is brain function imaging that is not necessarily connected to a certain behavior classification. You'll see that there's a close correlation between behavior and brain function, because the way you work or the way I work or the way our behavior is definitely directly related to how your brain is working. So that's why I call it autism in quotation marks from the scan standpoint, and also from the inside out. Remember, we have modern medical technology. We're looking right in the brain. We're not looking at behavior. We're just seeing what the brain tells us about. So in a certain sense, what I'm doing is that, like the subtitle is making a case for brain function imaging rather than only looking at behavior observations. Now I'm asking you, just like Temple Grandin asked us to stretch a bit and keep stretching. During this presentation, I'm asking you to stretch a little bit, and it's intended to be thought-provoking. And so, like, if I've done my job, hopefully you will have stretched a bit, you will have learned something. Hopefully you'll have like a new context in which to look at brain function imaging in relation to how you experience the autism situation on a clinical basis. So, in a certain sense, this isn't a talk about autism. It's a talk about how would we understand anything about what the brain is doing using modern medical imaging technology. Just for the commercial plug over here is, yes, you want to know more about me, you can go to Drspectscan.com. And although I'm based primarily in Southern California, I'm also affiliated with a site in Florida, which happens to be called NeuroSpect of Florida. My background, as I said, is not in the world of pediatrics or psychiatry. My background's in internal medicine as well as aviation medicine. And I'm board certified. Although I was in the UCLA system, I've primarily been in private practice in the Southern California area. However, in this day and age, imaging is all electronic. So I actually look at scans and are sent scans from literally virtually anywhere in the world, because with a push of a button, they can show up on your computer screen. So I'm used to seeing studies from other places in the country, although I'm physically sort of located in one predominantly in Southern California. And yes, I haven't really counted the number of autism scans that I've looked at. In other words, I've been involved with this work for 20 years. And it was serendipity. I was not involved with pediatrics or anything, but in about the early 90s, somebody called me up one day and said, hey, doctor, I know you've been doing brain function imaging. We have some children with cerebral palsy we're trying to help them. And could you help us? Because we don't know what to do or how to see or what have you. So I said, oh, okay, I'll image some children with cerebral palsy, and which became more children, which got me into the autism world and the hyperbarics world. It's been a journey for the last 20 years, and the journey's still ongoing, and I'm actually having some fun doing it. And yes, I'm one of the, I don't have any special needs child. My experience is really having talked to hundreds of families who have people in the autism spectrum, and those when they've come in the audience or the office or what have you. I literally got a sense, sort of as best I could, what it's like for you to deal with these things on a, it's not just 24/7. I mean, the way it occurs to me, what number of you have to be with this as is, it's beyond 24/7. It's like 36/8 or something like that, because I know that it's an ongoing activity for you. And so, yes, in this presentation, I'm going to tell you something about brain function imaging. In other words, I'm not going to try to describe all the technology that's out there. Dr. Herbert alluded to some of those, more of the technologies that we're still bringing to clinical fruitfulness. I'm going to talk to you just about like the basic things that are available now. And then I'm going to engage you right now in some possibility thinking. In other words, I really want you to like create with me like a fresh context for how you would be looking at brain imaging, and as a way to look at it separate from whatever behavior patterns have been telling you. And lastly, one of the predominant things also I'm going to mention are comorbidity issues. This is like some of the newer work that Dr. Kaplan's been asking me to talk about. Basic idea is that we had like a certain belief system about how these scans and functions should look, and early imaging did that. And quite frankly, sort of I've observed some things over the last several years, and I'll show you specific scans about that actually tell you that there's a number of other things that are going on in individuals who are in the autism spectrum. We call them co-occurring or comorbidity issues, things like unknown or underlying seizure disorders or PTSD patterns or anxiety issues or things such as this that you couldn't ordinarily guess or figure out just by looking at behavior. And so I'm going to describe some of those findings, and we're actually beginning to suggest possible therapy implications about that. But first, just to engage you in a little bit of possibility thinking. Oh, excuse me. Got one slide ahead of myself. We're already using medical imaging in a lot of these conditions. And I highlighted, and the pointer doesn't work, so notice that with closed head trauma, there's a whole lot more conversation out in our world about that. It's primarily been focused on National Football League players, but there's a lot of weekend warriors and others, and even children who are playing contact sports who are getting brain injury. We now know that it's not a good thing to get your bell rung. That's always a brain injury. Now, it turns out the brain has a lot of plasticity, and it's able to recover from a lot of things. But remember, the brain has the consistency of soft butter, and it's in a hard shell. And if your brain is about 2 pounds, like a 2-pound block of soft butter, and you accelerate the head, whether it's from a blow or what have you, you got 2 pounds of mass moving at some rate of speed, and it impacts the inside of your skull, which is a hard structure, and it gets injured. And we know now, even in our service personnel, one of the biggest issues is blast injuries. And so there's a lot of traumatic brain injury. Just be aware that brain function imaging has been around and been looking at for a number of years. Dr. Grandin mentioned about the Department of Defense doing one thing. She's got, there's a scanner somewhere in Pittsburgh. I'm going to comment on her slides a little bit. But the fact is that there's a lot of work that's already been out there about looking at brain function imaging, so-called traumatic brain imaging. I've got a lot of experience in that, and I'm not going to talk about that in any greater detail today. So what's new is looking at autism, but looking at it in terms of overall brain function, looking at learning disorders, seeing what comorbidity issues are there and what that might mean in terms of the way that they complicate your management of the clinical presentation of autism in your individual. Now, I just want you to be listening very powerfully, not because it's about me, but it's not only about the message. I want you to be thinking about listening for other people in and around your life and in your community. In other words, not everybody could be here. What are you getting? What's the something new? What's the aha? Hopefully there's something in the way that I present an idea, or at least create the context for you to think about a possibility that you say, gosh, you know, I never heard that before. And that you're able to communicate that to a variety of other people, because I can't talk to everybody. So this is a little audience participation. I can be very serious. I can do this very easily. And Dr. Grandin certainly got things moving in a very warm-hearted fashion. In order to do that, I just want to create a little audience participation with you just very briefly. So that on the next slide, I'm going to show you, there's going to be a picture there. And what I want you to do is when you look at the picture, just blurt out, just speak out, whatever is the first thing that comes to your mind when you see the picture. Are you ready? Okay. What I'm pleased to hear is that fish out of water. I have this poster in my office. Most people who walk in and look at that poster say, oh, that's about thinking outside the box. And I say, well, wait a minute, where are the fish? They're not in the box or in the bowl. They're actually outside the bowl. And they're not only outside the bowl, but they appear to be doing pretty good outside the bowl. So my intention is to request that as you not be thinking outside the box, but actually be seeing, like, how could you be with this information literally out in your world, being alive and communicating this with other people, and be thinking in that larger dimension. I'm seeing at least one yes, okay? And I'm also asking you, as we look at things, is to suspend value judgment for a while. In other words, information as we look at it isn't necessarily about what's good or bad, or that right or wrong, or that there's necessarily one right answer, or as Dr. Grandin alluded to, we're not really quite sure what's normal. There's a lot of normal variation. So as I talk about things, I encourage people to say, this looks like typical scan findings or typical behavior, rather than say, that's obviously abnormal and this is obviously normal. And as I said, I just ask you to think about the larger dimension also. What are you going to share with people subsequent to this? Now, there's some myths that are out there, and one of them, of course, is that there's no cure for autism. Now, quite frankly, right now, we don't know exactly what that is, and it's probably not going to be one thing, but I like to come from the standpoint, and I have a number of pediatricians around me. Remember, I'm in like standard medical practice, so a lot of pediatricians still say, look, nothing can be done about this. Now, I know that you know that there are things that can be done about this, but I'm really present still to the fact that a number of my physician colleagues say, like, we can't do anything about this. And I'm a believer that we can do something about this, although I admit I don't know what the cure is at this moment in time. I'm also at times to speak with psychiatrists, so I'm a believer in the fact is that there really isn't mental illness. I'm not going to go into a discussion about the DSM-5 or what have you, but clearly this is still, the context here is looking at brain behavior and what does it tell us, independent of whatever diagnostic category somebody wants to stick on someone. Okay, what I heard is audience participation. It's in the brain, it's not in the mind. Okay, and I'm seeing some other yeses. Okay. Now, in terms of just a little more possibility thinking, just to know that we're stretching the envelopes with some things, as Dr. Herbert has said, is like, you know, let's get rid of this fixed thinking. Now, I know I don't have to tell you this, because you know this, you're the advocates for your kids, but we're still present to that. There's a lot of belief system that there is no, things are kind of fixed, and we're working on systematic ways of improving outcomes. It was surprising to even some psychiatrists recently, just in terms of like thinking out, not just thinking, but being outside the box. Some psychiatrists recently reported they were surprised that some schizophrenics got better on antibiotic therapy for some other medical condition that they had. Or, pardon? Why are you not surprised? Time doesn't permit us to have a full discussion of that, but that's okay, I appreciate that. And even, for example, SSRIs are used in people in the autism spectrum, and recently there's some information that says they might have an antiviral effect. And at times, viruses have been implicated as playing some role in the autism spectrum situation. This is all relatively new information. This is all preliminary, but at least inside of being outside the bowl and being okay with that, looking in the larger dimension, sometimes the answers are going to come from areas of knowledge that some people call the areas that you don't know that you don't know. And lastly, even one of my referring colleagues says that, you know, autism, and maybe in a number of cases, may actually be some other medical disease. So we're using molecular or medical imaging. I just encourage you to just like think about it in some new and fresh way. We're using evaluation of brain function to see what it tells us. We're not compelled to make a diagnosis, because the diagnosis of autism is a clinical diagnosis. Someone looks at the behavior pattern and says, you fit in this particular category. So we are not attempting to use brain function imaging to make a diagnosis of autism. The idea is to just look at the brain without some fixed notion about things and see what it tells us. What can we learn? And some of the imaging that's been done thus far, doctors, like the first course that you take in medical school is anatomy. So it's like doctors' default button whenever they want to look about something is they think, well, how can we take some anatomy pictures and see what we can find? And yes, there are some structural abnormalities that have been shown in the autism spectrum in a smaller percentage of individuals. Now, we're still advancing in the technology, so there's likely more to be found, but at least in terms of functional imaging, in my experience at least, 100% of the individuals in the autism spectrum have at least some kind of atypical brain function. So I'd like to make the case that it makes at least some logical sense to be looking at brain function imaging and not just behavior, and not just anatomic imaging. So autism is really like a neurological disorder, a medical condition. It's, as we've already sort of agreed, is not mental illness. And we have medical imaging technology, and what we've been using the technology is to actually look at areas of the brain. Remember, we're talking about function imaging, at least I'm speaking about function imaging. We're looking at areas of the brain and stating what we think are areas that are overactive and areas that are underactive. And how could we use that information, as in point 3, how could we use that to document any changes along the course of therapy? Or what I'm speaking on is how could we find comorbidity issues that we couldn't see without brain imaging and which complicate your clinical management of the situation. And I'm going to speak a bit more about that in a short while. I'll show you a couple of cases. I'm not going to show a whole lot of brain scan images per se, because I want to get some basic points across and not show you 50 cases of findings. So right now we're going to go to the point number 1, which is just talking a bit about brain imaging and the medical technologies that we have available. Fundamentally, the way to get a good handle on this is to say we have 2 basic categories. We have anatomy imaging, or structure imaging, and then we have function imaging. And inside of anatomy imaging, the 2 most common things that you'll find in any hospital environment or what have you is the MRI and CAT scanning, also known as CT. And these are magnificent, wonderful things. We're getting fantastic anatomic detail, no question about it. What they don't really tell you is how the tissue's working. Now, we do have function imaging, and the two acronyms applied to that are SPECT imaging and PET imaging. And because all of these things usually have fairly long number of words, we just use acronyms for all of them. Fundamentally, SPECT, actually not fundamental, it actually stands for Single Photon Emission Computed Tomography. Now, there's just some basic points that I just want you to get over here. That you get what's the anatomy imaging, what's the function imaging, and then some practical points. And that is that the anatomy imaging usually, and especially if we get to functional MRI, which I'll talk about in just a little more detail, is that basically when we have to image individuals in the autism spectrum, they can't cooperate. I mean, they can't hold still for 2 minutes, let alone for 20 minutes in a scanner. They just can't. So we are able to, because of the way SPECT technology works, is that we actually inject the patients before they ever get in the scanner, and their brain function pattern is determined by what the brain is doing when they're injected, not when they're being scanned. So that means we can inject them, let the tracer substance distribute in proportion to brain function, and only after that fact do we actually give the children some sedation so that they can actually sleep through the scan for about 20 minutes time. Now, another thing that's important is to notice that, and you'll see on the images, when we take an image for 20 minutes, we're actually gathering the whole brain volume of information at one time. So we're not doing separate, you will see slices, but the information is gathered in a whole composite packet of data and then only subsequently processed for individual detail. There are some other imaging technologies, such as people are taking MRI, which, as I said, is primarily anatomy-based, but people are attempting to extract additional information by having individuals perform MRI images. I realized, wait, let me just stop right over here and just talk a little bit more about SPECT imaging. I realized that I had changed the course of slides. So just in the two basic forms of imaging, which is anatomy, which is MRI, and SPECT imaging, which is function imaging, the top row are just 3 representative slices out of an MRI study of the person's whole head. So there's multiple images, but just for the purposes of conveying an idea, I have just 3 representative images. So we've got great anatomic detail with MRI. In the middle row is a function study, happens to be a SPECT-scan, and they're usually in color, with the color scales being used in a way to represent different degrees of activity. In other words, the concept is that the distribution of the tracer is proportional to functional uptake in the cells themselves. This is not angiography. Although people talk about blood flow, this tracer actually is taken up in the brain cells. So it's about cellular function. And we grade them and use different color scales. The color scale right now, for our purposes, isn't important. What's important is to say, here's an example of whereby we have structural anatomy imaging on the top, and in the same person we have functional imaging in the middle row. And of course, because this is in the computer, we can actually package this together and make sort of what's called fusion imaging, namely that we could overlap these pieces of functional information on the anatomy structure and make better decisions about what's the level of function in this particular area. Now, Dr. Grandin showed us that she was generous in showing us some of her own, what is personal health information. And we respect that. We appreciate her generosity in sharing some of that. And she's agreed to let me at least make a comment or two in regard to that. Because what I saw was that in her imaging, she's really showing you an example of sort of a more advanced form of functional MRI. In other words, how can we take those anatomy images and get function information as well? And so as she showed you, is that she was able to get or these scans were done with her on an advanced scanner that's not available in your hospital, so you can't get this in your standard hospital situation at this time. But what she was able to show you is that her structure is different than what somebody else thought was a normal age-match comparison. Now, the thing that I just want to convey over here is that this is still structural information. Now, this is good information. We need to find this out. We need to know what are the connections in the brain. People have said, well, you know, in autistic individuals, the connections between the brain, parts of the brain are different. They're different than normal individuals. And there is some atypical patterns to this. The thing that I want you to at least think about is that even though we're looking at structural detail, the question, at least for me, coming from more functional imaging than just structural imaging, is that I see that there's a different pattern to the structure. And it would imply then that there should be some different function going on in the individual who has one type of wiring pattern versus individual who has a different type of wiring pattern. From functional imaging, I'm still asking the question on what's going on in the cells that are beyond the wiring pattern. In other words, if either one of these was the wiring pattern or the wiring diagram of a computer, and if we said that the Grandin computer had this wiring structure and the normal had this wiring structure, that still doesn't completely tell me what the computers themselves are doing. So I'm making the case for the fact that although we're looking at structural detail and we're getting closer and closer to doing that, and we're doing that based upon a person's actual function inside of a scanner, there still is a role for looking directly at what are the cells doing, and that's why other forms of function imaging can still come into play and be useful. And the bottom line is that all the imaging technologies that we have, they all have some limitations. In other words, there's like no one scan that we can do on everybody to figure out every diagnosis. We're going to be using some combinations of function imaging. Dr. Herbert actually mentioned something like that yesterday. She's got a system that is sort of like a hybrid system that puts together PET imaging and MRI for more direct imaging visualization and correlation. We're going in pathways like this. But right now, things such as basic SPECT imaging that you could access don't come in those hybrid packages. They come in standard sort of applications that I'm going to show you about. So just remembering, we're talking about the function imaging patterns and the way that that happens. In other words, the way that the scan actually occurs in, say, like your child, is that the child gets an intravenous injection of a tracer substance. The important thing to realize is that we're actually looking, as Dr. Grandin said, it's like the key is also in the biochemistry. So we're injecting radiotracer substances that actually interact with some element of biochemistry. So this is in vivo biochemistry that we're looking at. And the radiotracer principle, which is from like 60 or 70 years ago, is that how can we use, and this is where the word tracer comes from, is that how can we use such a trace quantity of substance to measure something, and it's so small, the trace quantity, that it doesn't disturb the organ system that we're trying to measure. And people developed ways years ago about how to do that, and so we inject what is a non-pharmacologic quantity of radiotracer to measure what's going on in a particular organ system. In this case, we're actually talking about a tracer that goes to the brain in relation to regional brain function. Now, as we're making these images, there's something important here. Remember, we're talking about brain function. And I just said, and I'll repeat it, is that what shows up on the scan, in the SPECT scan, is what the brain of the person was doing when they were injected, not when they were in the scanner. So we can inject somebody, and the usual scan is done with a person in a resting state, in a quiet environment, in a semi-darkened room. But we'll get a completely different function pattern if we inject the person while they're doing some activation. And the usual activation testing and the usual clinical application thus far has been to uncover facets of attention deficit disorder, with the concept being is that the person at rest, basically the way we function as human beings has a lot to do with what our frontal lobes are doing. We know that the rest of the brain is also very important, but who you are as a person and what kind of thinking and planning that you can do really depends upon how well your frontal lobes work. And so the basic concept is that the person who has attention deficit disorder, when they have to recruit their frontal lobes to do something that's a cognitive challenge to them, that their frontal lobes don't work as well. And therefore, they need some sort of stimulant. And so we can actually do, and this is a common practice, we don't do this in autistic individuals, but a common scan practice is to do 2 scans on a person. One with the person in a baseline resting state and one with them doing activation testing. The idea being, and the general concept is that a person who really doesn't have attention deficit disorder can recruit their frontal lobes, and therefore on the scan, the frontal lobes don't look abnormal. Whereas if the person has some what's called executive dysfunction, when they do a challenge test, an activation scan, their frontal lobes actually do become abnormal, or since we're not using normal, we'd say changes or shifts or decreases function from their baseline state. And I'll show you only one example of that in an autistic individual just to make a point very shortly. Now, as we said, the scan takes about 20 minutes. The good thing is that we can actually sedate the children so they can hold still, and we can get a high-quality scan. We're using intravenous sedation. We've done a better part of 1,000 children like this with complete safety. And what's important, and I've talked with a number of the autism doctors or what have you, is that there's general agreement that intravenous sedation doesn't really cause any particular problems in children, and particularly it doesn't cause regression. This is what a scanner looks like. Basically, the important point over here is that unlike MRI scanners where you usually have body completely inside the system and they're relatively noisy, and so it takes a bit more patient cooperation. With the SPECT scanning systems or most PET imagers, you actually can have most of the person's body outside of the camera system. So in other words, there's a little white arrow there that I can't really move around with this system, but that's where the head is placed, and the rest of the body is outside of the scanner, which slowly revolves around the person's head for about 20 minutes. But it means while they are sedated, the anesthesia doctor is fully present, has full access to the person, and is able to take care of any safety issues. And we've had just wonderful and very 100% safety doing it just this way. Now, the images that come out of here, this goes back to the old radiology of making grayscale pictures. So at first they were grayscale pictures, and we made multiple slices. Then we embellished them and put in some color scaling to give functional information. But what really makes a difference is transitioning this slice information into 3-dimensional pictures that you or I or anybody could fairly easily grasp. And that's what's on the right, let's see, it's on your right side of the screen. Namely, here's 3 or 6 pictures of this person's function image, of SPECT image. Namely is that the arrow, the white arrow is pointing to the right side, so this is the right side of the brain. And the color scale is saying, wait a minute, there's an area that looks like a black hole right in the middle of this right side of this person's brain. Now, I'm not going to describe all the technical details to this, but the color scale that's employed here says that by looking at the color scale, I can tell levels of function throughout the brain. Remember, this is gathered all at one time in just 20 minutes, and the person didn't even have to cooperate for this. And what we've learned in terms of function is that this is a color scale that's actually, which we learned from different testing procedures, is set up so that the black zone starts at about 40% up on the color scale, which is in the left-hand margin of that image. But what we've learned is that we actually can tell some tissue viability at times. In other words, something that's literally a black hole is probably dead brain structure. Now, what we really key on and what the important message is over here is that not this one thing. This happened to be a brain scan on a 20-year-old woman who had the equivalent of a stroke, happened to be a traumatic brain injury. And what her physicians were focused on for 2 years, so this is a scan that's 2 years after she's had this stroke, lost a part of her life, namely from having been an active, young, growing person, able to go to college and what have you. After this devastating injury, she couldn't really function at that level anymore. Everybody was focused on the fact that the left side of her body was weak. And the purpose, again, of this is to say, we looked at all the functional information. We didn't just look at that one side of her brain. And what people hadn't taken into account is that she was struggling not because she just had this one lesion area over here, it's because other parts of her brain. Look, I mean, her brain pattern over here isn't really uniform. It's really very irregular throughout the front and back parts of the brain. People hadn't focused on that. And what happened, and this is not a presentation about hyperbaric oxygen therapy, but she's one of the cases that we have of hyperbaric oxygen therapy where we could actually improve her brain function in all the other areas of her brain such that she could get her life back, even though we couldn't fix the one spot over here on the right side of her brain. This is the purpose, I believe, it's one of the strongest reasons why you would do this whole integrated brain function imaging, so we don't get caught up in looking at just one point of function in one part of the brain. And normally the presentation of this, just to keep it simple, is just in some grayscale imaging. And usually the presentation that you'll see in a number of slides is fairly uniform, and it's fairly well integrated throughout the brain. In other words, there aren't any holes, which would mean that there are areas of decreased function. So this is what a so-called normal or typical brain pattern would look like. And over the last several years, the conversation has been, well, there's areas of decreased function in the brain associated with the individuals on the autistic spectrum. And indeed, we can find that there are areas of decreased function in individuals who are in the autistic spectrum. And the little thought control arrows down there and that I can't move say, well, there's a decrease of function in the left temporal lobe, the right temporal lobe, part of the cerebellum. And this is a common pattern. In fact, we can see variations of this pattern in almost all autistic individuals. Now, it's to a greater or lesser degree. So that the thought was that, well, there's areas in the brain associated with autism are areas of underfunction. That's what we're looking for. That's how we'll make some decisions about treating. But as we were doing the scanning, we also found that there's some areas, in this case, the overfunction areas are the red zones. There's some areas that appear to be functioning at a higher level than what we were looking for. And initially, many of us just overlooked those things because we didn't know what to do with that information. And it's only over the last several years that several of us have been looking at this together and saying, well, there must be some meaning and maybe some clinical application to areas of overfunction as well as the areas of underfunction. And in point of fact is that one of the real observations that I'm reporting on is the fact is that at least 90% of individuals on the autistic spectrum have areas of overfunction as well as areas of underfunction. So we're looking at, well, what could be the meaning of those areas of overfunction? For instance, this is a scan on an individual that, as you can see on the gray images, have areas of decreased uptake. So there's hypofunctioning, underfunctioning, underactive areas of the brain, okay? But wow, if we just change the way we look at the images, in other words, it's the same piece of data, and if we just threshold the data in a different pattern, we can see that, and if we said to the computer system, show me only the areas in the brain that are at the highest 15% of activity throughout the brain, just show those on the picture, erase everything else, what happened in this particular individual is, wow, a whole lot of this person's brain is really overactive, diffusely overactive. Now, this is not the most common pattern, but I use this because it's a dramatic slide, and it makes the point, is that in individuals now we're learning that there are areas of overactivity, areas of underactivity. There's a variety of patterns in those, and in some of these individuals, we can actually draw some possibilities in terms of what that might mean clinically. For instance, like in this particular individual, there's an arrow at the top of the red image where it says cingulate. This is a part of the brain that's sort of like a connection structure between the brain. It's some of the structural data or what have you. And in this person, this area is overactive. Now, what might that mean? Well, one of the things we've come to learn is that people who have this overactive pattern in the cingulate, they're usually the people who can't shift their attention. And as Dr. Grandin talked about, sometimes there's a problem in attention shifting. And indeed, we've been observing is that in individuals who have difficulty with attention shifting, some of them have the so-called red-hot cingulate, and there's an actual functional anatomic reason why this person has difficulty with attention shifting. And some people believe that we could use some medications to make a difference in that pattern to help these individuals. And this is just a more complete example of looking at under and over function. So what's been happening is that we've been focusing more on what are the hyperfunctioning, what do the hyperperfused areas mean? And we've, at the bottom of the slide, it says we've been implying that there's certain clinical representations of this. In other words, when I see a hot cingulate on a child, as I was talking with a mother on a phone consult just 3 nights ago. She had had a scan. We were talking about it because she actually went back to Texas. She flew from Texas to get a scan. We were talking about it, and I said, well, your child has this area of the brain that's really overactive and so forth, so there's very likely going to be some obsessive life. She said, is that the reason why Jimmy, or I don't remember what his name was, spends 2 hours in the kitchen with the door opening and closing, opening, closing, opening, closing the door until the hinges fall off? She said, how do you know these things? I said, well, we were looking at brain function here. So, some basic practical questions. Why would you get a brain scan? And the underlying question is, why would you spend money? These scans are like $1,500 or $2,000, so they're not cheap. This is not a $50 scan or a $250 screening study. Why would you do this? Why would you spend money? And I know that all of you, it's a real cash issue because, if you put the A word on any insurance form, it's like guaranteed, like you don't get reimbursed for the services. So I know that you're looking at cost-effective things to do, and so I'm not saying get a brain spec scan on everybody. I'm saying, well, why would you get a brain scan? Why would you, under what circumstances, spend some money to do this? Well, first of all, is that sometimes the extent of disease can't be told just by looking at the behavior patterns. Sometimes it's just important to know that there's 10% or 30% or a greater portion of the brain involved with some particular level of dysfunction. And many of the disease issues that we're looking at are multifactorial. In other words, there's inflammation, there's toxic factors. So, in other words, in the autism community, your conversation isn't just like there's like one functional abnormality and we never have to consider toxic factors and we never have to consider trauma factors. We never have to think about, is this a child that does head banging or didn't do head banging? There's multiple factors, and one of the things is that the brain function scan is pretty good at capturing a whole lot of information in one shot. And then lastly, it enables us, it's enabling us to talk about comorbidity issues, and that's actually should be coming up on one of the other slides. But also there's another reason about getting a brain function scan, and that is to allow you to subsequently ask better questions. In other words, Now that you've actually seen brain function on any one person, you go back and you look at the clinical situation of that individual, and you're going to, because you will have gotten functional information, you're going to ask some more questions that you didn't think about asking the first time through. The most common occurrence of this is not really about autism, but it really has to do with traumatic brain injury. In other words, most people, if I asked most of you if you had a traumatic brain injury, most of you would say, no, you didn't have that. And actually, let me just ask you, how many of you have had a traumatic brain injury? Raise your hand. Okay. Well, the reality is that even more than that, and you're honest people, you're decent people, but most of us deny that element where we might have gotten a little bit of concussion. Oh, you mean got hit in the head by a baseball? That might have had something to do. Oh, I fell off the swing. That didn't really mean anything. Guess what? Those things do mean something. And so what we've learned is that if we can see evidence on the scan of injury pattern, we go back to that person and ask them some more detailed questions, and people can then recall. Usually what we find is you have to ask people 5 times before they say, oh, God, I didn't know that wrestling accident when I got knocked out might have had any impact on my life. So the point is that functional information, even after you attain the scan, can allow you to glean some more specific, clinically important information. One example of that is in talking about the comorbidity issues is that under the category of PTSD, now, I want you to get, we're never going to put a psychiatric label on any of these children, okay? So I'm never going to read out a scan and says there's PTSD in this person. We're not doing that. However, there's a certain scan pattern that we've come to learn that looks fairly consistent with individuals who are experiencing what clinically is called PTSD. Now, one of the things that's occurred is that a couple of examples of that is that, like you have an 8-year-old child probably, unless they did some head banging, probably didn't have a lot of physical trauma. But one of the things that I've done, and this has only been 2 times, but I commented to the mother about this, and she actually, I said, is there any possibility that this child has experienced some bullying? Because, as you know, these children can't necessarily tell you how they're feeling. They can't talk. They can't necessarily describe their feelings. And this has been 2 instances where, even though the child was in a special care situation, the parents looked back and the child was actually experiencing some bullying. Now, I'm not saying we're using the scan for this purpose, but I just want you to get a sense of we're just beginning to understand a lot of the clinical applications that could come out of just straightforward looking at the brain and saying, brain, tell us what your function means. So let me just complete with just one thought over here, since I got so enthused that I actually went beyond my time. Here's just a mom who flew her kids over from Hawaii. We did scans on her children. And she said, prior to having the SPECT-scan, and I know that you can read, it says, it felt like we were navigating our son's treatments in total darkness. We completed the scans, and what I showed her was that her children had been on a certain therapy regimen. They had both been considered to be in the attention deficit disorder spectrum and were on stimulants for 4 years, and they weren't getting better. We did scans on them, and what I showed her was that, at least from the scan point, her children don't have the equivalent of attention deficit disorder. And because they had red-hot brains, a lot of overactivity, those stimulants were probably not helping them. And what she came to understand was that their children were on the spectrum. They needed a different medication and other therapy approaches. And as she said, this is Debbie's own words, is I wish we would have started with a SPECT-scan 4 years ago. It would have saved us a lot of frustration. And lastly, just to make a certain point, is that in terms of getting a scan, Just the fact that someplace has SPECT technology, which can be applied to cardiac imaging, it's the standard for cardiac imaging as well as for bone imaging and other things. It just simply means we're doing tomographic imaging, in this case of brain function. Places can do SPECT scans, but I can tell you, and this is my recommendation, because I see a number of scans that get referred to me. You get scans at some places whereby there's not enough detail on the scan. All of us as doctors don't know everything. We just simply don't. And even those of us who are in subspecialties don't even know all the things that are in those subspecialties. So there are doctors who do brain imaging, or at least a lot of radiology, who don't necessarily know how to look at brain scans, SPECT scans, in these children in the autism spectrum. So my recommendation as I'm completing is to say, brain scanning, SPECT scanning can be very helpful, but don't get it or do it only if the imaging site actually does brain SPECT scans and not just SPECT scans, that they actually have done a couple of dozen kids so they actually know how to scan them and be with them, that they actually know how to safely sedate these children for the scan, and lastly, that the doctors actually have some experience in interpreting these scans inside the context of looking at brain function in the autism spectrum. So I thank you for your attention. I thank you for using your brain function during this presentation.